Today I'm going to discuss LADA, or latent autoimmune diabetes in the adult, which is an area that I've long felt perplexed about, and I don't know how to define it. Nobody knows how to define it. The ADA doesn't know how to define it. And yet, a group of people from around the world have just published in the journal Diabetes a consensus statement about the management of LADA in adults. And this consensus statement is basically defining LADA and then talking about how LADA should be managed. And I don't entirely agree with this, but I think it's a good starting point. So I'm going to discuss with you what they say, and then I'm going to tell you what I think, which is somewhat different. So they basically say LADA really are patients with adult onset diabetes who share features of having type 1 and type 2 diabetes. They say they resemble people with type 2 diabetes by not requiring initial insulin treatment, but have immunogenic markers associated with type 1 diabetes, primarily anti-GAD antibodies. They say that they account for 2 to 12% of all patients with adult onset diabetes, and based on this, they think we should have a deviation from the standard treatment guidelines for treating these individuals, treating them based on changes in C-peptide levels. So they have a table which is basically called characteristics of LADA. So these are the general characteristics that they define. Age at onset greater than 30 years, a family or personal history of autoimmunity, a reduced frequency of metabolic syndrome compared with people with full-on type 2 diabetes, lower HOMA, lower body mass index, lower blood pressure, normal HDL, compared with people with type 2 diabetes. They say there's no disease-specific difference in cardiovascular outcomes between these patients and those with type 2 diabetes. They say that C-peptide levels fall more slowly than in traditional type 1 diabetes. They state that positivity for anti-GAD antibodies is the most sensitive marker, but that other autoantibodies can be found as well, just less frequently. And they state that this form of diabetes is non-insulin requiring at onset. The authors define 3 categories of LADA based on random C-peptide levels. The first level are people who look a lot like people with plain old type 1 diabetes, and the third level are people who look like regular old type 2 diabetes, and then there are those in the middle. So category 1 is defined as a C-peptide level of less than 0.3, and these people are treated with intensive insulin regimens. Category 2 are individuals with C-peptide values greater than or equal to 0.3 and less than or equal to 0.7, and these are defined as individuals who fall into a gray area, meaning maybe they need some insulin, maybe they don't, but you may need to follow them more closely because they have antibodies and low-ish C-peptide levels. So they recommend using a modified ADA-ESD algorithm for the treatment of type 2 diabetes, with the caveat that one may need to start insulin therapy earlier than in other individuals in order to help modulate beta cell failure and to limit diabetic complications. And then in category 3, which are C-peptide values greater than 0.7, they recommend a different modified ADA-ESD algorithm in which C-peptide levels are monitored in order to address treatment. In terms of treatment of patients with LADA, I'm not going to go through all of their algorithms, but I'm going to tell you the basics. So you just have to remember that these are patients who have the evidence of autoimmunity and they have varying C-peptide levels. And if a patient isn't responding to type 2 medications, you're going to use insulin. And you're going to be more likely to use insulin sooner because, as a clinician, you know in your mind that these patients are relatively insulin deficient. And then in their algorithms, they recommend against using sulfonylurea agents because they're concerned that these will burn out the patient's beta cells, although I'm not sure that this was based on a lot of data. And they also recommend being a little bit cautious when using SGLT2 inhibitors because they're afraid if these patients are more like someone with type 1 diabetes, the risk for DK could be increased. And finally, in their algorithm for the patients who look most like plain old people with type 2 diabetes, those with the highest C-peptide levels, they recommend monitoring C-peptide levels to determine which treatment to start next. And this isn't based on any real data. No one's ever done this before. And I don't know if I entirely agree with it. I think we tend to follow patients clinically and look at their response to varying therapies. But I think this is a good start because it's beginning to create a framework for defining LADA. It's beginning to create a treatment paradigm based on whether or not these patients have residual beta cell function. And I think it leads us to many questions for which there are no answers, but at least it's a beginning to try to help us out of the muddle of defining what is LADA. This has been Dr. Ann Peters for Medscape.